Hello again. Now, this is really, really exciting, this discussion, because in our work at point of care, we're really, really facing this shift. And so we thought this is perfect for us to come together as a community and, yeah, kind of find out what the lay of the land is and why we're here and where we are in this particular time.
Yeah, and it's particularly cool to have a TV here that I can see myself. So that's
He likes seeing himself.
that adds to it. But no, yeah, I think this is really important. You know, there's so much that goes on, as we know, with sickle cell disease, but ultimately, to the broader community, to our own community, pain still really ranks pretty high as the significant characteristic of sickle cell disease, and it's personal for all of us, as we said. And I'm really interested to hear what our panelists and our presenters are going to be speaking on, because I think that that's going to give us some insight, and we want to hear from you guys as well, as we just get feedback and response to that. And this is actually very timely for me. You know, my youngest son just went through a really tough time with pain in Dallas, and so it's something that's really top of mind for me. So yeah.
And I think for me, because my daughter's older and was, started on opioids at 2, and we know sort of what she needs and what works for her. And so we're at this point now, we're kind of looking at it and saying, how do we change it, right? If it really is a matter of tolerance, then how do we lower that? And I know 10 years ago we were looking into it, and at that point they were talking about having to put her in an induced coma and bringing her. So it was really kind of like, well, scary, so we said no. But I think this conversation needs to also talk about the fact that there is certainly age, right? Age, and that's part of this conversation, because it'll be really different for new moms. New moms will have tools. New docs now have tools. We used what we had, and seeing what people have in other countries, I'm so grateful that we have access to that. But now it's changing. So, that's affecting us. We get so many calls, and we're thinking we're going to have to come up with changing our behavior. But how do you change behavior when you're in the middle of an acute? That's like saying, I'm having a heart attack, but I need to change how I treat my heart attack to us. So this is really going to be informative.
Yeah, and I think the speakers that we have really provide that spectrum of thought. So, we're going to start with the pharmacist perspective and hear about that. And then Dr. Cantor will be talking more of the physician. And then we'll have a panel of the community that's going to be looking at, okay, what if it doesn't work? And I think that, so I think when we cover all those different aspects of the program, we're in for a really interesting and thought-provoking discussion. Exactly, that's what I said too. And so, that's what we're here to look forward to. And I think we're trying to
speed this up,
because I see the 4:35, so we want to make sure we can start. And I think our first presenter is virtual, and that's going to be on. And I understand that I don't need to introduce him, because you're going to have this fancy
I like
introduction here, I think. So we'll just take a seat.
Yeah, we'll take a seat.
Thank you, guys.
Thank you.
Our next session in the Shift in the Management of Pain 360 block is titled Pharmacist and Drugs: Why Other Drugs Are Being Considered. We are pleased to introduce Dr. David Dadiomov, PharmD, BCPP, clinical pharmacist, and faculty member at the University of Southern California's Mann School. Dr. Dadiomov also serves in clinical practice at Los Angeles General Medical Center, where he works directly with patients to improve outcomes in complex care settings. He is the leader of the initiative Transformative Chronic Pain Management for Sickle Cell Anemia Patients, which earned the 2024 Safety Net Innovation Award for advancing equity in chronic pain care. His work not only bridges pharmacy and patient care, but also challenges the medical community to rethink how pain is managed for sickle cell warriors. Today, Dr. Dadiomov will share insights into why other drugs are being considered in pain management and how pharmacists can play a pivotal role in shaping the future of care. Please join me in welcoming Dr. David Dadiomov.
All right, thank you very much. I appreciate that introduction, and really honored to be speaking here today. Again, I really wish I could be there in person with you all. I'm David Dadiomov. I am a PharmD, so I am sharing the pharmacist perspective. I know we're kind of starting in a multi-part series here, and we're going to be focusing on different medications, particularly on buprenorphine, a medication you may or may not have heard of, but I think you will be hearing more of in coming months and perhaps even years. We'll talk about how this is kind of shifting sickle cell disease pain management. So a little bit more about me. So I'm based out of Los Angeles and practice in Los Angeles General Medical Center, our large county public safety net hospital, and I'm a faculty member as well. So I do some teaching and research as well to make sure that the next generation of clinicians are aware of how to treat these complex health needs with the latest evidence-based literature as well. So for this session, we're really going to focus on identifying some of the limitations to current therapy. So in the vein of, why are other drugs being considered? First, we have to consider, well, what is and isn't working about, the status quo, what we're doing right now. We'll describe buprenorphine's unique pharmacologic advantage. So I'll approach that from the pharmacist perspective, but I'll weave in some clinical and real world examples there as well. And then we'll analyze some of the clinical evidence that is emerging and is more of it is coming out as we, even by the week, we're seeing more and more published in this field. So I think this is going to be really great for helping improve the level of care that we deliver. So I know the session is short, so I'll just get right into it. This needs really no introduction that, the current pain management setting, over 100,000 individuals with sickle cell disease, with multiple hospitalizations per year. And I know the average number seems to be around 2 or 3, but of course we've seen patients who have multiple hospitalizations, month after month. And that tells us that maybe something that we're doing can be improved. How can we develop and implement, solutions that work for the community? Of course, as we know, pain is that number one reason for emergency department visits. It spans acute pain, chronic pain. We'll talk about all of those. And we know that there are published guidelines. The Department of Health and Human Services in 2014 published an evidence-based management of sickle cell disease. So of course that's over 10 years old already. So there's a lot of things that aren't included there. The most recent thing, the thing I've seen a lot of warriors cite are the ASH guidelines. So the American Society of Hematology, the 2020 guidelines. So those are already 5 years since they've been published. And the big takeaway from those is that we really just need more evidence. A lot of this is based on clinician opinions, kind of expert opinion. And it's of course guided by warriors in the community as well. But what we need is more concrete evidence, because what we're seeing is that pain management is a really severe problem, something that we really need to tackle and tackle effectively at that. And so the traditional approach, so when we talk about why other drugs are being considered, well, the conventional approach is opioids, of course, and that is our approach to a lot of types of pain. This isn't, going to be a session where we bash opioids. We need them. We absolutely need them for a variety of different functions that they serve. What I will discuss is that there are times when we can have issues with opioid treatment where it may not be optimized as fully. Of course, there's plenty of patients who are doing fine, that are stable and maintaining. They found the regimen that works for them. And so, of course, this isn't necessarily geared towards them. But what we've been seeing, locally and keeping track of what's happening on a national level is that many individuals are seeking alternative treatments, alternative pain medication regimens. So we'll talk a little bit about those. So what are the problems with current opioid treatment? Of course, there's opioid-related complications. Well, any drug you take is going to have side effects. So that's nothing new. Opioids can have somewhat mild all the way to severe side effects. Things it can cause some drowsiness, constipation. But of course, we also know opioids can be deadly and lethal at high doses. People can overdose on them. There are both intentional and unintentional overdoses. Accidents can happen, especially as doses escalate, as they get mixed with other treatments, therapies, or even other drugs. There's, of course, a huge amount of healthcare disparities and a large amount of bias in the healthcare system as it relates to sickle cell disease treatment. This has been very well documented. This is something that affects individuals as they seek out treatment. This can make people more hesitant to seek out treatment and create issues in actually accessing the evidence-based treatments that we know can be effective for individuals. Of course, in the emergency department, when people present with in those acute crises, there are challenges associated there with getting treatment in a quick fashion, being able to address all the unique needs with balancing all the other things that are happening with regards to the chronic disease management as well as the acute pain crisis that's presented at that very moment. Of course, as anyone who's had an experience in the emergency department knows, that is not an experience that they are seeking to repeat on a regular basis. So, really minimizing the amount of time that people are spending in emergency departments or having to visit the emergency department. It really ought to be a major goal of ongoing research as well as the treatments that we provide for patients. One of the biggest limitations that we have is with chronic opioid therapy, though. So a lot of the data for opioid therapy is great when you look at a short-term time frame, but people who need opioids long-term for months or years at a time, that is where the data gets a little bit murky, and that's been known for quite some time. And it's highlighted in the ASH 2020 guidelines as well. So we know that there are limitations. So as you continue to use opioids, your body does develop a tolerance to its effect, requiring higher and higher doses. And we know that sometimes that doesn't always increase the efficacy of the medication, but it can increase adverse effects and toxicity associated with that medication. I'll also talk about on the next few slides some of the imbalances that can occur when you take opioids long term, some of the brain changes that can actually happen. In addition to those chronic opioid limitations, we know that there's problems with access and resource disparities, again, from the healthcare system, as well as even if you find the perfect drug that works for you, sometimes you'll go and try and get it filled from the pharmacy and they won't have the medication, or the insurance company won't pay for it, or the clinic that you have to go to get it prescribed or administered is across town and you have to take off work just to get an appointment there. There's all kinds of barriers that can make it more difficult to access the preventative treatment, and that ultimately leads to problems down the road, which can even lead to increased hospitalizations if you can't access the preventative treatment. And then pain itself is complex. So I don't mean to oversimplify it or act like there's just one solution for every patient. There isn't. And pain itself is very complex, and there isn't just one thing that causes it. And it's not just pain receptors and chemicals in your brain. It's related to people as well. We know that there are, of course, mental health conditions. There are socioeconomic things and societal things that occur that can change pain perceptions and ultimately make it more difficult to access treatment. So we have to consider all of these things. We're not just looking at one thing in a bubble, and recognize the complexity. And I think by recognizing that, we can start to tease through, well, what's going to work and what isn't. So all of those things can contribute to making it difficult to achieve, the goals that we all have for, living successful lives and, going about our day-to-day activities without any kind of pain, things like that. But sometimes medications can actually make that more difficult. And so when I talked about some of those brain and body changes that can occur when you take opioids for a long time, we call that increased pain sensitivity. So over time, what conventional opioids do is they increase your sensitivity to pain. And that seems counterintuitive because I thought opioids treat pain. Well, for the most part, they do, and in the short term, they do. But when you take them over a period of time, your brain receptors start to recognize, okay, we're getting this pain receptor blocked. Maybe we don't need it. So your brain starts to make fewer pain receptors. And that may seem like a good idea at first until you recognize that when something painful happens to you, you are just more sensitized to it. So if we think of pain and pain relief as a seesaw, what we're really seeing is that balance between pain and pain relief is getting thinner and thinner. And it's a lot easier to tip the scales because things that may have not been painful to you before suddenly are painful because your brain has been more sensitized to those pain receptors. And this is something that's been long-standing and known with chronic opioid therapy. And so opioids can do that. How do we combat that? Well, I guess you can increase the dose of the opioid, but then you're still going to end up in that cycle. And it's, again, very difficult. That's how many patients end up on very high doses of opioid medications. So over time, it actually makes it more difficult to actually treat and manage that pain. Now, of course, we know that some of the challenges that individuals with sickle cell experience are healthcare bias, significant healthcare bias, that even coming into that emergency room is a dreaded experience because of the stigma associated with that. And it's been documented in other research that a lot of providers incorrectly assume that people with sickle cell disease are more likely to have an addiction disorder. And that's a myth, that's a misconception. The truth is that people with sickle cell disease encounter addiction disorders at the same rate as individuals in the general population. So there really isn't a difference there. Having the sickle cell disease, having the trait isn't something that would increase your risk for addiction. And it doesn't justify taking a more cautious or measured approach. Now, again, as we mentioned, opioids do have risks and benefits with anyone. So, of course, a good clinician should be considering those for any patient as well. But there's also been a disparity in the degree of pain relief and prescriptions that were prescribed to sickle cell patients. And that was actually made worse following the CDC's updated opioid guidelines in 2016. Of course, those guidelines had good intentions because we had seen over 10 years of opioid-related deaths as a result of prescription opioids. It's hard to imagine a time before fentanyl when the number one cause of drug overdose deaths was prescription opioids prescribed by prescribers. But that was the case. And so these guidelines came out, and all of a sudden the pendulum swung in the complete opposite direction, and people had less access to opioids. And that created a whole slew of other problems. But some research came out that showed that sickle cell patients were more adversely affected by those guidelines and by people tightening up on opioid prescriptions. And so, again, these things warrant consideration. We have to look at what the data is telling us and making sure that we are not exacerbating these biases and disparities within healthcare. To that point, there's also, of course, systemic failures, time delays in receiving pain relief. I've heard a lot of unfortunate examples of people who needlessly waited for, prolonged periods of time to actually receive pain relief, get the medications prescribed to them. And what I'm seeing a lot in talking to my colleagues through our own work here in establishing novel protocols for sickle cell pain is that there's a lot of inconsistency across even large institutions. And that means that patients are getting different levels of care, having different protocols, different algorithms, depending on where they are. In some institutions, they may be seeing a hematologist, and others, they may be seeing a primary care doctor. Some are seeing a pain specialist, some are seeing a psychiatrist or mental health professional, others are seeing an addiction medicine specialist. So there isn't a set way to care for patients with these painful chronic pain conditions. And that leads to a lot of heterogeneity in terms of what types of services people get, depending on who their providers are and what those particular protocols are. So, again, this is highlighting that we do need more researchers and clinicians to engage in helping to develop and disseminate what those best practices are. Of course, we already talked about the stigma associated with healthcare utilization. So that is a huge issue, and that simply returning to a hospital, returning to an emergency department, and somehow stigmatizing a patient for that, I just view that as wrong. That is really a failure on the healthcare system that failed that patient and that family. And so we need to look at those instances and say, what can we do to do better to help prevent these painful crises, from occurring. So again, this isn't intended to kind of, bash conventional opioid treatment or anything like that. We need it. Many patients do just fine on it. It's not something that, most people are addicted to opioids or anything like that. But there are a significant number of patients who are seeking better outcomes. They are in and out of emergency departments, or their functional status is not where they want it to be. They're living with chronic pain conditions. They're having more and more acute painful crises. And so, what can we do about that? Well, let me introduce what I think is a highly underutilized medication. It's buprenorphine. It's also known as Bupe, or some of its brand names that you may have heard before are Suboxone, Subutex. It's also available as an injectable medication called Sublocade or Brixadi. And this is an opioid, so this is why I'm calling it the other opioid. So it acts at the same receptors as other opioids, the mu opioid receptors, but it acts a little bit differently. And many people know Bupe in a different setting than from pain management. And I think I don't know exactly why it got more popularized in one versus another, but I have a feeling marketing has more to do with it than the science. Because when you look at it, it was approved, or it was discovered in the 1960s, and it's been FDA approved since the 1980s, originally for pain as an analgesic. And then it got approved for the use of opioid addiction about 25 years ago. And many people know it as the drug that people use when they're addicted to opioids. If they were addicted to fentanyl or heroin, sometimes they may get a prescription for Suboxone. And we don't hear about it as much as a pain medication. I think some of that has also caused some bias against this medication. Needlessly so, because it is a terrific pain medication. And I'll explain why. But first and foremost, it's a very potent opioid. So it binds much stronger to the opioid receptors than just about any other opioid that we have. In fact, if you're taking another opioid medication and you take buprenorphine on top of it, the buprenorphine will just kick off the other opioid on the receptor. It is like a magnet to those pain receptors. And the difference is that its pharmacology is it's a partial opioid agonist instead of a full opioid agonist like conventional opioids. So what does that mean? What that means is a full opioid agonist, and again, these are conventional opioids. This is Dilaudid, hydromorphone, oxycodone, Norco, hydrocodone, morphine. All of those are full agonist or conventional opioids. They bind to those mu opioid receptors and they activate them fully. Whereas bup, on the other hand, binds and it's a partial activator. So it activates it partially. The way I like to describe it is it's like a light switch. And imagine you have a dimmer switch on your light bulb. So conventional opioids, they just turn that light on to the max. It's the full illumination that you get. But you know, sometimes you don't need that full illumination. It causes a glare on the computer screen or, you know, hurts your eyes. Um, Sometimes if you just, you know, turn the dimmer switch to 60%, it's perfect. You can still see everything you need to see. Your eyes don't hurt. There's no glare on what you're doing. And so it works like that. It acts at the same receptors, but it activates them a little bit less. So as you would imagine, the adverse effects are similar, but a little bit less. So instead of causing the sedation and grogginess and severe side effects like respiratory depression, it can cause a little bit of sedation, but way less than that of conventional opioids. Same thing, it causes less constipation. And it is one of the safest opioids that we have because it has a ceiling effect on the respiratory depression, meaning it's virtually impossible to actually overdose on this medication. Now, remember I talked about the pain receptor sensitization. When you take opioids long term, they can oversensitize your pain receptors. Well, buprenorphine has less of a risk of doing that over time, and that means it's much safer and more effective as a chronic opioid therapy than things like Dilaudid or oxycodone or any of those other opioid medications. Now, you might be thinking, okay, if it's a partial opioid agonist, if it's not activating those receptors to 100%, is it not as effective at treating the pain? And that's not true either. So, both from patients' perspective as well as from research, it is shown to be as effective, if not more effective, than other conventional pain medications. So just to highlight that safety profile, these are two different graphs that showed that buprenorphine has that ceiling effect. And you see it compared to fentanyl on the left here, where the more fentanyl you get, you can see the x-axis of this graph is more fentanyl, and the y-axis is ventilation, or kind of a measure of your breathing. So the more fentanyl you get, the lower your breathing is. And that's how people die from opioid overdoses. Once you have too much opioids in your system, your breathing reflexes slow down. And once you stop breathing, you stop getting oxygen to your tissues in your brain. And that's how you die. With buprenorphine, even as you increase doses of buprenorphine, your breathing rate slows slightly, but it never goes to that level like you see with fentanyl, where it's dangerous or at risk of causing death. So you might be thinking, okay, but how is it actually for pain? And so let's hear it from patients themselves. And on the next few slides, I have some of the recently published literature that came out. And again, this is stuff that's getting published recently. This was just published last year, but some of these articles I'm pulling from were published in the last month or two. And more are coming. I can see on some of the upcoming journals where things are getting published and some of the trends. But in this one, I particularly like it because they actually interviewed individuals who had sickle cell, who have sickle cell disease, and got transitioned to buprenorphine for pain. And it's like a transformation. People, again, this is a quote from one of those individuals. They say, I can function. I can really focus and not be dozing off, looking into space, or not be in a subdued world. I'm more productive. I'm more active. And that just goes to show, I mean, buprenorphine has the same pain relieving effect. It just has less of those side effects. So people feel, less sedated, less of that opioid groggy effect. And there's a lot of other anecdotes, so I encourage you. I pasted the citation there. You're welcome to look into that and see how other people have responded to the transition. this one is relevant for of course people who have ever been in a hospital. Um, this is a study out of Johns Hopkins. They've been doing a lot of great work in sickle cell disease over on the East Coast. And what they studied here was a protocol where they transitioned people from their opioid to buprenorphine and assessed, well, how did they do? So this wasn't something where some major event happened and they had to transition them. These were people that were relatively stable and doing fine. They just transitioned them, see, can we improve their outcomes? And of those patients that they did, they saw that the average for their hospital visits, most patients had about 12 visits per year on average. So that was, going to the hospital or the emergency department at least once a month. That dropped down to on average of 5 visits per patient once they transitioned to buprenorphine. And again, a lot of the questions that people have, well, because it acts differently, is it going to be as effective for my pain? There was no difference in their pain control, meaning patients still had adequate pain control. Now, remember, these were patients who didn't have a problem with their pain control before. So they were relatively stable before, and then they were relatively stable afterwards. So this is very encouraging research out of the East Coast, similar to what we're doing here in Los Angeles. But again, I don't mean to paint it as all roses. There is, of course, a process and a protocol for doing that. So transitioning to buprenorphine does require careful supervision. If you're on full agonist opioids, especially if you're on high doses of them, it has to be very carefully transitioned to buprenorphine. And that has to be done under the care of someone who's familiar with how buprenorphine works. That could be your clinical pharmacist, it could be your pain physician. In a lot of health systems, the addiction medicine team, and that's why the addiction medicine team is getting involved in sickle cell disease pain management because they're so familiar with buprenorphine. It's not because these patients are addicted to opioids, but they're familiar with how the medication works and they're familiar with treating pain. And so they can help transition individuals to buprenorphine. And we've been seeing tremendous results. A lot of patients have been doing very well with this new treatment. Again, from what I've been able to tell, few are aware of it, and so we're trying to increase that awareness and figure out what's the best way to help individuals address their questions, making sure that they have all the information at hand. But this isn't, a patient-centered approach is key, and so that's what we always employ. So we always want to make sure that the patient's comfort and pain control is number one. We make sure that anything that we're doing is going to be in collaboration with them. So if we need to go slower on a medication taper or a dose adjustment, we don't rush anything. There's no rush to get someone on a new medication. And again, this is just for people who are looking for alternatives to or feel that their current pain regimen has not been working for them. And fortunately, again, out of the East Coast, there have been more of these research on those conversions. So again, this is specific to sickle cell disease. If we look at the broader research on pain management, like chronic pain, other types of pain, there's a lot more research on buprenorphine, which I didn't include here because I wanted to focus on the sickle cell research. But you can see in this research study published in the American Journal of Hematology, they were able to convert people relatively easily. And people ended up, in this study, they ended up on relatively low to moderate doses of the buprenorphine. Again, likely because it is so potent that you don't need to be on such high doses. But again, there is a wide dosing range, so there's room for adjustment there. In this table, they listed the most common adverse effects that were actually related to the medications. And so there was an instance of withdrawal where perhaps the medication was started too early or at too high of a dose. But the response to that is simply increasing the dose. And again, it's kind of a temporary discomfort that does go away. There's, as I mentioned, other systemic barriers that like insurance access and things like that which can vary depending on where you are. Um, an isolated kind of instance of tongue numbness or headache that can occur when you take the type of the medication that goes under the tongue. So that is, one thing to consider. And then ED visit for treatment. So again, if you don't have access to the treatment, if you, for whatever reason, can't access a provider for any of these things, then an ED visit, what was necessary, at least in that one patient who experienced that. But I can tell you, from my experience that individuals, when they transition, they do very well, and it's encouraging to see individuals kind of living without having to worry about dosing the drug so frequently or having the pain sensitization or the adverse effects of opioids. But again, it's not a one size fits all approach. So every patient is different, and we approach it that way. But again, wanted to highlight in this presentation some of the other drugs that are being considered and share that we are trying to add more to the research body because as we see more call outs from organizations that we need more guidance, we need more science and funding towards these healthcare interventions. So with that, I'll conclude my talk and turn it over to much more important is Q&A and any questions or perspectives or comments I'd love to hear. Thank you all very much for your attention.
Thank you so much, Dr. Dadiomov. Do we have any questions from the audience?
Yes.
Is there?
Yes, here.
Oh, so we'll take one to the right, our right, and then our left.
Hi, yes. I was introduced to BUP not a few months ago, and I definitely see the benefits. However, I was wondering whether it would be actually effective when I'm having a serious crisis, acute serious. I can't imagine, but what kind of dosage would be necessary? Right now I have 2 packets. One is 150 mcg, the other is 300. I understand there's not an overdose. It would take a lot to overdose, but I'm wondering how much would be required, and everybody's different, I understand, but generally speaking, to manage a serious acute crisis.
Yes, excellent question, and I'm glad to hear that it's been working well for you. So, one great point that you highlight that I didn't mention. So remember when I said that there's a ceiling effect in the respiratory depression, basically the adverse effects, the really serious adverse effects that it's virtually impossible to overdose on buprenorphine. The same is not true for its pain relieving effect. So in that study where I showed that graph where more doses of fentanyl decreased your breathing rate, whereas that didn't do that for buprenorphine. Higher doses of buprenorphine can cause more pain relief. It doesn't stop like it does for the breathing depression. And so what that means is that if you have an acute crisis, even if you're taking a baseline dose, and it sounded like you were taking a patch version of it, you can add more on top of that, even if it's just temporary. Now, that doesn't have to be your new dose, but even if you add more doses while you're in that acute crisis, it can still provide extra pain relief. So there isn't a limit on its pain relief, especially in the hospital where we have access to certain hospitals do have also like injectable forms where you get a higher dose and even higher doses that you give under the tongue. We've seen very high doses, given for patients that are inpatient, and then as they stabilize and the acute crisis goes away, we're able to transition them back to their normal home dose. And so the good news is for a lot of people who are taking that patch version, so I didn't mention that was also Butrans. It's available as a patch. that's actually very low on the dosage regimen. So that's doses of about 2 to maybe upwards of 4 milligrams of sublingual equivalent. And just to give you a frame of reference, the FDA has approved up to a maximum of 32 milligrams of sublingual buprenorphine. So being at about 2 milligrams, you still have kind of 16 times more way of those dosages to go. And again, pain is a multimodal approach. So in an acute crisis, it's not just the opioid, it's not just the bupe that we're using. There are other things, other non-opioid medications, if needed, anesthetics and NSAIDs and ketamine and all kinds of things that we can kind of combine, as well as even non-pharmacologic things, right? So using non-drug things. And the more tools that we have in our tool belt, the better off, the better we can treat that specific patient.
Great. Thank you so
So
much.
much. Thank you.
I think what we're going to do in the interest of time, I want folks to hold their questions because I think Dr. Cantor is actually going to answer most of the questions. So we'll catch whoever, we'll get you right after Dr. Cantor and the gentleman who was over here. If your question has not been answered by Dr. Cantor's presentation, then please, we'll call on you to go. And Dr. Davidoff, thank you so much. We really appreciate it. And another round of applause. And
So I think our last talk was fabulous, and the reason I was trying to say, hey, let's do questions at the end was because I didn't want him to give my entire talk, because he did such a wonderful job. I use a ton of buprenorphine in my practice, and I'm gonna tell you a little bit more about it. When I was given this topic, I'm not gonna lie, I kind of cringed. I was like, whew, this is like being a goldfish in a room of sharks, right? Talking about opioids and what's wrong with them, or what's bad, or what's good, or what the world thinks. That's a pretty tough topic. I spend, I would say, 75% of my clinical time talking about opioids. And I have a lot of concerns with that. And probably the biggest one is that people in other areas of medicine actually forget that some people with sickle cell disease don't have pain, but that doesn't mean they don't have problems. In fact, I've seen now recently a 65-year-old who was referred to me, and he was referred by our transplant nephrology team. So he had been sent to UAB because he needed a new kidney. And he was mostly seeing a primary care doctor and a nephrologist. And everybody, when I said, why haven't you seen someone like me, a sickle cell specialist? He lives only an hour away from me. And he said, well, I wasn't having pain, so I must not have been that sick. His kidneys were dying from his sickle cell disease. And so when we think about drugs and pain, I want to remind everyone about the other things that can happen in sickle cell disease. And so pain is unbelievably important, but it's not everything. And sometimes the doctors don't do a good job of recognizing that. These are my disclosures. And y'all did not just say I had 30 minutes because you said I had 30. But anyway, okay. So we'll talk about the push away from chronic opioid therapy from the sort of political standpoint, some specific concerns for individuals living with sickle cell disease, and then some of the new non-opioid drugs, as well as some of the updated recommendations that we have from the National Alliance of Sickle Cell Centers about opioids and use. So where'd the push come from, right? Why did we go from everybody should talk about pain, we get your blood pressure, we get your oxygen saturation, what's your pain level? When did pain become the fifth vital sign? Well, you can actually thank Purdue Pharmaceuticals for that. That is really where it came from. They actually pushed pain meds on doctors in ways that are regrettable in many ways, but mostly because at the time they told a lot of doctors that you couldn't get addicted to our pain meds, right? That didn't happen. And it was a big lie. But they brought something really important at the same time to the forefront, which was looking at pain. How do people feel? And that was really important. So there was a good side to it as well. But where did the opioid epidemic come from? Well, it's clearly a severe public health crisis, and it's driven by the high rates of addictions that we see and death that's been related to both prescription and illicit opioids. But most of that has very little to do with sickle cell disease. So why are we stuck in the middle? What are opiates? They're this natural compound. At the end of the day, it all comes from opium, right? All of them in some ways are related back to opium. There's lots of different types with lots of different names, and all of them are slightly different in the way that they work. But most importantly, they all block pain receptors. So often when I've asked individuals living with sickle cell, what do you do for your sickle cell disease? And they tell me, well, I take oxycodone. And I said, well, but that's not treating your actual sickle cell disease. What are you doing for your sickle cell disease? And they kind of look at me blankly. It's important because the pain medicine just tells your brain you don't hurt. It doesn't help your blood flow. It doesn't help things get unstuck. And it doesn't help you live longer or stronger with sickle cell disease. And many individuals that I have met through the years, no one's ever really said that to them. They've actually not been told that the pain medicine doesn't fix the crisis. It just helps the brain get through the vaso-occlusion. And so it's something I really now go back to the basics on every time I talk. What about the opiate epidemic? Well, it got really bad, and it got really, really bad in the United States. The opioid epidemic and what we're seeing in terms of deaths is very much a US-based problem. And this is really important because the way we use opioids in the United States is incredibly different. And even in the context of people living with sickle cell disease. I know when we think about other places with sickle cell, we think about sub-Saharan Africa, and oh, of course they're not using as much opioids. I'm talking about England and France. In England and France, there are no children sitting at home with oxycodone. They don't use that medicine at home. If you need something that strong, you have to come to the hospital for it. And so hearing Adrienne earlier talk about, her daughter getting opioids starting at 2 years of age is something we desperately want to avoid moving forward. Because first of all, it sets an unrealistic expectation for you. If you have pain and this is what pain relief becomes, how do we ever get better than that? But also because it creates an unnecessary habit as opposed to looking at other ways to manage pain. And that's not just in sickle cell disease, as this graph kind of tells us. What else about the opioid epidemic? Oxycodone is actually the most widely used recreational opioid in the United States. It's the most diverted opioid from prescriptions. It sells the best on the market, in case everybody wanted to know, about $40 a pill. You can look that up. You don't even need the dark web for that. And we've estimated that 11 million people have consumed oxycodone in a non-medicinal way. In our clinic, it's the most diverted opioid. There's a lot of reasons that I know that, but the main one is from the evidence of urine drug screens, which I'm going to talk about in just a minute. How did people start on opioids? Well, mostly because they were given a prescription. So about 1 in 10 individuals, when given a drink of alcohol, will become an alcoholic. About the same is true for opiates. So it's true. The fact that people have sickle cell disease has nothing to do with whether or not they end up with an opioid addiction. It's being given an opioid at the right time in their life that might trigger that addiction. And so 1 in 10 people, this could happen to anyone, right? You go have a tooth pulled and somebody gives you Percocet and you realize, that made me feel a little bit better. And I feel a little bit worse when that Percocet goes away. So I take another Percocet like any other human would do. And through aggressive opioid prescription practices, that's actually what really triggered the opioid epidemic that we ended up in. And as a result, when this all happened in 2016 and the CDC came out with new recommendations, doctors pulled back. Unfortunately, they didn't increase the number of psychiatrists. They didn't allow for people to get more mental health care. This is people in general. And so when they pulled back from opioids, what did people have left? We did such a terrible job of managing this in the United States. They had heroin and they had fentanyl coming in from Mexico or China or who knows where it comes from. And as a result, we saw this illicit increase because we didn't give people what they really needed was a program to get off the opioids that some doctor accidentally got them hooked on. So it was a real failure of medicine. And I think pretty badly of the medical field for that. So that's a lot of where we're headed on the political side. But what does that really have to do with sickle cell disease? Well, there is no data that suggests that individuals with sickle cell have a higher rate of opiate abuse, but we know that people with sickle cell disease have a higher rate of opioid use because there's more pain. As I said, the more you get exposed to an opioid, the more likely you are to spring on someone who happens to have an addiction Or worse, we the physicians cause the addiction. Well, what does that mean? Well, I was taught when I was a young resident, now I get to say that because it was long enough ago, that every patient I took care of, every child I took care of living with sickle cell disease, when they came in for a pain crisis, I should send them out of the hospital with OxyContin and oxycodone. I'm not going to tell you who taught me that. But it took me a long time to understand that perhaps I wasn't doing anybody any favors. So we were exposing. But it's also caused other problems. Right now, when you need a specific opioid, I have to call 17 pharmacies to find it and then do 17 PAs to get it approved at that pharmacy. So that creates a lot of hassle that doesn't help anyone, doesn't help patients, and doesn't help providers. But it's also really increased the scrutiny, the attention paid to us. So I've had some visits to my office from the DEA. They've come to my office to say, wow, you prescribe a lot of opioids. What are your practices? And I'm not the only physician in sickle cell disease that's had this happen. But it's a lot of why we do the monitoring that we have to do so that we can keep prescribing safely and being allowed to prescribe. When I was in South Carolina, I also had my DEA stolen. So that was really fun. And my signature stolen. And we had some smart pharmacies who realized that this wasn't me prescribing those opioids. So that's when it was still on paper, but printed. And I mean, they were good and they got better. I got to see all these iterations. Apparently it was a drug ring out of Chicago that started this. So there are real problems out there, and there are unintended consequences. Another unintended consequence is the woman in my hospital who claims to have sickle cell disease. She has 5 different names. 5, same person. Why? Because ID is not required when you go to a hospital. She had multiple Medicaid numbers as well. What didn't change was her age, weight, and allergies. And that's how I tracked her in the system. She does not have sickle cell disease. But there are a lot of those individuals out there, and they're making life a lot harder for individuals we take care of. So if we become more careful in our prescribing, we can fix this problem. She doesn't come to my hospital anymore. So when we are prescribing opioids, what do we have to do? Like, what's the burden on me as a physician? So first we have to decide, is it the right drug for you, the person sitting in front of me? Now, as an adult provider, I rarely get to make that decision, right? Most people come to me and say, I've been on this and this works, or I've been on this and it doesn't work. So we have to talk about that, and we have to talk about why it does or doesn't work and what that means. Because sometimes people will tell me, well, it works. And I would say, but you were in the hospital 8 times, in last year. That doesn't seem like it's working for you. Well, but it works when I take it. And so I said, yes, it works in that 30 minutes or hour. Then what? So it's not working if you still have to go to the hospital very frequently. How do we select opioids and doses? There's very little magic behind it. And so that's also really important to know. There's calculators, but there's not great weight-based dosing that we can use. And it becomes really complicated. When should you use an extended release? You don't get to learn that in any books. And what we've learned over time is deciding that initial opioid prescription and doing follow-up. A lot of doctors aren't very good at it. Here's your Percocet, call me for refills, see you in 6 months. I'm not helping you as an individual because that means I'm not checking in with you. Hey, how are you doing? Is this working for you? Do we need to change anything? And so when we started putting these together in terms of best practices, we talked about if you start something, have a plan to stop it if it doesn't work, have a plan for very frequent follow-up, and make sure that you're reevaluating benefits and risks. We have another, I could tell you stories for days, but one of my favorites was the patient who had not had a bowel movement in a month. A month, can you just imagine? When she came to the hospital and said she had abdominal pain, what do you think that she got? Dilaudid. Why? Because she has sickle cell disease, and we've done a really great job in some places at training individuals, doctors in the hospital, please treat pain, treat it aggressively, that sometimes we actually forgot to say, but please ask someone what's happening in their body and their life and making sure you ask the right questions. Sometimes people living with sickle cell disease, and I've heard it a million times, I know my body, I know my pain. Our bodies aren't that smart. They play tricks on us. And so this one woman thought that pain was the same. She said, no, it's my sickle cell pain, until she also noted that we hadn't had a bowel movement in a month. So recognizing these things is hard. And pain stinks, and there's a lot of fear. What if this time the pain doesn't go away? What if this time I stay in the hospital for a week or a month, or, right? So we have to put all that together when we think about this. So we have to think about the benefits, but also the risks and the harms. And that's where it comes to some of the scrutiny that we're under as physicians, and the reason we have to check the prescription monitoring database, and the reason we have to do urine drug screens. Because if I give you Percocet and I haven't paid a lot of attention, and it just so happened that the psychiatrist down the road was giving you Valium, and you didn't tell me, but you went home and took your Valium and your Percocet and you died because you stopped breathing, that's on me. And that's the scariest thing you can think about as a doctor. And so we have to make sure we're doing as much due diligence as we can to be safe. So if you've heard us talk about the PDMP, it's a statewide program that helps us track prescriptions. And it's a very important step to improving opiate prescribing practices, and you learn a lot. And it's important because if I'm initiating opioid therapy, I want to see what someone has gotten before. Sometimes people don't know what meds they have or haven't had. If I'm continuing it, I want to see how often people are filling or having to fill early. And if I'm in the hospital and I don't know you because this is the first time you've ever walked into my hospital, that's really important too. I've had people ask for levels of medicine that would truly cause them to stop breathing. But if I know what they've been taking at home, it helps me quantify what they need more. However, when do you not have to check? Well, when you walk into the hospital with an acute pain crisis, I don't need to say, whoa, wait a minute, let me go check PDMP, right? Let me give you some pain medicine, treat the pain in front of you, and then go back and make a longer term plan. And I think that's something we have to start differentiating. So moving into people with sickle cell disease, why do we worry so much about chronic opioid therapy? And thankfully, the pharmacist before did a great job of giving this part of my talk. But first, pain truly is both physical and emotional. Well, what do I mean? Well, I have a 14-year-old daughter. I mean, that should tell you enough right there, right? She has a migraine, but oh my God, she has a party tonight. You better believe she's going to that party, migraine or no migraine. Same migraine, now she has a test. You think she's going to take that test with a migraine? Right. I mean, pain is how we can deal with it in the spirit of what we're doing at that moment, how we're feeling, and what our emotional and social settings are. And that's just human nature. So as much as it's a physical sensation, it's an emotional sensation as well. And we can't fix that. We can't change that. We just have to recognize it. This is a very old article that really points that out. Yes, there's tissue damage, but how we incorporate that tissue damage into our mindset is a whole experience. It's very, very hard to understand, even for those of us that spend time studying it. We know it has to do with emotions. We know it has to do with social contact. If you live in certain places where pain is not permitted, you're going to internalize that pain in a very different way to where it's expected. And you can think about how that would change if you were told you couldn't cry. What are you, a wimp? Who do you think you are? You think you need medicine? And I've heard this from people. The way you internalize that pain may be more depression. How can I feel like this? I must be doing something wrong. What am I feeling that's wrong with me? As opposed to what's wrong with my body and how should I fix it? So you can imagine that these perceptions of pain differ significantly between people. How does pain work? Again, it's the most highly modulated sensory experience in the body. Why? So I put my hand on a fire, right? It's gonna burn me. That feeling has to go up my arm, into my brain. I have to think about what it means and then send the signal back that says, move your hand. If you give me some pain medicine, it's not gonna change how much I burn my hand, but it might change how close I get to the fire. And this goes into what he was talking about before, about hypersensitivity as well, but I'm going to explain it to you in a slightly different way. And I change these analogies up over time to see what resonates, because different things make more sense to different people. That makes sense, right? So you heard somebody earlier talk about having retinopathy or eye problems from sickle cell disease. What does that mean? Well, it means that the retina, which is the nerve bundle in the eye, doesn't get enough oxygen. And our body thinks it's way smart, and so the body makes new blood vessels so it can get oxygen to that nerve bundle. Except those vessels aren't always very well designed, and so they break and bleed and actually cause more problems. When you block those blue arrows in my diagram up here, when you block that pain receptor, your body goes, why can't I feel pain if I'm still getting burned? I'm still on the fire, I'm still getting burned, what's wrong? Well, what do you think your body does to respond? It makes you feel pain more. It creates more pain receptors. So tolerance is not the way we think of it. It's not that you need more medicine because your body believes that medicine is not effective as much as now you have more pain receptors that need coating. And as a result, you end up needing more and more pain medicine to coat all those pain receptors. The other way I like to explain it is someone who takes oxycodone every 4 hours, and I blame oxycodone a lot, so you'll hear me use that as a reference. That person taking that oxycodone every 4 hours, it just begins to feel like a warm coat. What happens when you take off a coat? You're gonna feel cold. And that's actually what happens to the body. All of a sudden the body's like, where's my coat? And how does the body interpret that? It gives you more pain. And so sometimes we see cyclic pain that's actually withdrawal pain medicine. A lot of ways to think about it. And we know there's a million causes of pain in people with sickle cell disease. And unfortunately, most of these aren't going to get fixed with putting you on chronic opioids, right? That's not going to fix the problem. And so we have to think about which problem we're trying to treat. So if you have avascular necrosis in your hip, that pain's going to hurt every day. I want to figure out the best pain medicine that's going to give you the longest lasting relief, that's not going to cause you to have more pain downstream, not going to cause you to make those extra pain receptors. If your pain is modulated by the fact that you're living in your car and your hip hurts more because you're living in your car, well, certainly more methadone or more buprenorphine, nothing is going to help that. I got to figure out how to get you out of your car, right? And so we have to really contextualize the kind of pain we're treating in the environment that we're treating with the right drug at the right time for the right person. And we have to consider pain due to withdrawal, which is why I put it in red at the bottom, because it's a real thing. Most people who are on chronic opioid therapy, the first thing they feel when their opiates wear off is pain. It's not the sweating or the vomiting or the diarrhea or all that other stuff that'll come later. And so to them, to individuals who have this, it's the same pain receptors that light up, because our body likes to do the same thing over and over again. So if your crisis was in your legs and it got better, when you weaned off the opiates or didn't wean off and just stopped them because you got better and went home from the hospital and wanted to go back to your life, and all of a sudden the pain came back in your legs, you're like, oh, my crisis is back. That's the logical thing to think, not, oh, I'm withdrawing from the pain medicine. So logic doesn't always help us out. What else do we know about pain? It's very different in different people. About 50% of people with sickle cell disease will develop chronic pain by their mid-20s. Chronic pain is not the same as acute pain, must be considered differently than acute pain, and we have to start treating these entities different. We know that not everyone with acute pain seeks acute care, right? Lots of people manage their pain at home. We do know that the more opioids you are often getting, the more visits individuals have to the hospital, in about 50% of cases. So sometimes going up on pain medicine isn't the answer if it's not helping you manage your pain. And what we also know, unfortunately, is the more times you're in the hospital, the more likely you are to die from sickle cell disease-related complications. Why? Mostly because hospitals are probably the least safe place to be. We want to do better, but let's be honest, right? You might have a nurse who's not checking your vitals as often as they should. You often will have a doctor who doesn't notice that when your oxygen saturation is getting lower, they need to call a specialist or do something. When you're taking opiates, you don't breathe as deeply. That's true of every human. But if you do that in a hospital bed that doesn't make you get up and move as much, you don't have the chance to take those big breaths. It's why we like day hospitals. You come, you get your pain management, and you try to go home for the night because the act of going home actually makes you breathe better and prevents the acute chest or the blood clot or the other things that might happen downstream. So when I see someone who's in the hospital twice a month, every month, I try to do everything I can to fix what's going on, whether it's pain, whether it's depression, whether it's both, because it usually is, because otherwise I know that individual is not going to live very long. And that scares me more than anything. This is a very long list of all the bad things we also know about chronic opioids that I'm not going to read to you. Yeah, you're welcome to take a picture of it because we're not going to read this. But I am going to tell you that just like any other medicine, opioids have bad things. They actually have more bad things than hydroxyurea. They have more bad things than some of the other medicines that people say I like to push. And it's important to recognize that because sometimes we end up treating the side effects of things more than we treat the problem. Why do we know all this? Why do I know that people with sickle cell disease get this chronic pain and this hypersensitivity? When we cure people, when we did a bone marrow transplant for individuals with sickle cell disease, sometimes their pain doesn't go away. And more than that, when they have pain, what they tell me is it feels just like my crisis. Except they have no inflammation, no hemolysis, none of the things we know happen in true vaso-occlusive circumstances. They may tell me it feels like when I had acute chest, but their lungs are perfectly clear and their saturations are normal. Why does that happen? Well, because of these funky pain receptors. Now you just have more pain and your body puts pain into categories, into what it's used to feeling versus not used to feeling. So it feels the same, even though it's not the same thing causing the problem. The other thing we learned, and this is a study by my friend Alexis and John Tisdale, and what they showed essentially is the more pain you had before a stem cell transplant, the more pain you had after a stem cell transplant. That pain begets pain, not pathology. It had nothing to do with how much tissue damage someone had. It had nothing to do with how much avascular necrosis or other damage was. It was everything about the frequency with which you had acute pain before equaled the frequency with which you had afterwards. The other thing that I learned, giving this a talk similar to this in Spain a few years ago, is that all the doctors looked at me blankly. Now, I was one of the only few English speakers in the room, so I was like, maybe I'm just not making sense. And finally I said, I'm looking at a face of a group of people who seem confused. And they said, we don't see chronic pain like this. We don't see this after transplant. So what do you mean you don't see it? Their use of chronic opioids is so much lower than ours, they didn't have this problem. It's another way that I started to look at what we were doing in the US compared to other places. So it wasn't just more crisis, but it was more opioids that were actually relating to more pain after treatment. This was actually what we just talked about before, about buprenorphine. And buprenorphine is a fascinating drug, or my friend Pat always says it's a funny little opioid. And this was the same study that he just quoted, and I call it the David Carroll protocol. Because we've now implemented it, and the two people who really founded it were Mandy David and Pat Carroll. And what they saw was that people had a lot of visits to the hospital before and a lot less after. It seems pretty clear, right? But when you looked at how they implemented it and how we then took it and brought it to my own clinic to implement it, the first thing you have to do is make sure that sickle cell disease is controlled. Because if you're having repeated pain episodes, just giving you pain medicine, right, it's not going to fix the sickle cell. So you've got to make sure the sickle cell is controlled. And when they did that and then used buprenorphine in a very regimented way, they saw this huge decrease. So then we did it in our program and saw a similarly huge benefit. I'm going to tell you my favorite anecdote in the last couple of minutes about buprenorphine and Suboxone. I have this wonderful young woman that I take care of. She's 33 now. And she was an absolutely miserable human when I met her. She had recurrent pain, recurrent acute chest syndrome, and she just was miserable. Depressed, unhappy. She was trying to work. She's a CMA. And I ran out of options. I tried everything. We went up on OxyContin. We went down on OxyContin. We went up on methadone. We went down on methadone. Nothing was helping. And I was shocked that she actually agreed when we decided to try Suboxone. But I think she felt at the end of her rope too. And a week after, she came back to see me and said, I've never felt this good in my life. And I'm really sorry I was so mean to you. She said, man, I was nasty. I was nasty every time and I hated you and I am so sorry. I said, it's okay, because we had to fight every time about how much pain medicine she was or wasn't gonna get, or when she was gonna be admitted and when she wasn't. My only problem now is that she still has sickle cell disease and she still needs to be on exchange transfusions because she had this horrible recurrent acute chest syndrome. Sometimes she just won't come in. And I've looked at her social media page and she's like, oh, if you have sickle cell, all you need is Suboxone. Not quite. You still need to get your sickle cell care. But she's a baby now, and she works full time. And every time I get to see her smile, I remember why I have these hard conversations. We already got a great discussion from a pharmacist who's going to do a better job than I am of explaining why buprenorphine is the way it is. I want to tell you there's some other options, right? There's Tylenol, there's Toradol, there's peripheral nerve block. Why we don't use more of that, I don't know, meaning the block that makes your leg feel better if you've just had surgery on your leg. There's muscle relaxers, which are quite useful in combination with other things. And they're non-opioid therapies as well. Ketamine, nitrous oxide, which we need to bring back and talk about more, and I don't have time to talk about it today, but I'm happy to share these slides. Lidocaine, which admittedly can work really well, but scares the bejesus out of me because it can also make your heart not work. And I like when the heart works, and I am not ready to turn that over to a hospitalist I might know not well enough. There's this really new therapy I'm really curious to see, and I'm actually submitting a proposal to this company because I want to know about this drug in people with sickle cell, if it's as magical as they say it is. It's a non-opiate, and it works by changing your salt channels. And I'm, again, happy to share these slides because I know I wouldn't have time to go through all of them. But it's a brand new drug. I got it approved with 1 PA. It only took me 1 attempt. And so I think it could be, if it works, then great. I should tell you that the individual that I gave this to, I didn't stop her opioids to give this drug. I said, let's see if this helps augment what we're doing, and then we'll talk about pulling back. Because I think if we just did one or the other, of course, very little feels as good as oxycodone. It's unfortunate and true. The other unfortunate part of that is that oxycodone makes your mood better at first until it doesn't. And so that can also be hard. So we don't want to just trade, right? We want to start something new and back off on something old. So how can we improve pain? Well, we have to really fix what we're doing in our kids. And I'm saying that as a reformed pediatrician. We cannot give kids a lot of pain medicine at home. I love my parents. I've seen some parents do things that I've done. What's easier when your kid's screaming in the backseat of your car because they're hungry? Is it easier to stop at McDonald's? Right. Then go to the grocery and get a nice healthy meal that you have to now listen to your kids scream for 20 more minutes while you get that food in them? Is it easier to give hydrocodone than it might be to give the ibuprofen that's going to take longer? Yeah. So we need to make sure that option's not as readily available. We need to be very aggressive in our IV treatment, but then we need to be less aggressive in our home treatment because it's the chronic opioids that are the problem, not what we're doing when you have an acute crisis. And I'm out of time, but I am going to tell you that we have some new standards and recommendations to help doctors, to help them know how to start implementing this therapy. And these will be published soon, but they're already available on our website. And there's a lot to them, and so I'm not going to spend the time that I already don't have trying to explain them to you, but I'm happy to talk to you offline. But I wanted to answer a question that was asked about buprenorphine first. What happens if I have acute pain? Because it's such an important question. And when we started the use of buprenorphine, we all got a little scared. It was new to us, right? And so we didn't know if it was going to work as well. And we didn't know either, because it has Narcan essentially embedded in the drug. So we worried, does that mean if we gave you full agonist opiates, you'd feel like you were having withdrawal? No, that's the simple answer. So I have about 75 people I think I take care of right now who take buprenorphine, and that's out of a population of about 850. And when they come in for acute pain, some of them get IV buprenorphine for their pain because it works for them. Some get IV Dilaudid and get a Dilaudid PCA pump, and they're just fine. So that option is still there. I think that's the biggest fear I've heard from sickle cell warriors. What happens if I have a crisis, right? That fear is just, and I get it, you've lived with it your whole life. So I want you to know it's not an either or, but it might be an and that changes everything for how you feel. And I'm happy to take any questions.
Thank you, Dr. Cantor. Thank you, Dr. Cantor. I think we have some questions. And I'm going to ask, did you still have a question? Okay, good. All right, and then we have one here. If you have questions after Pat, think about jotting down your question, so you have it really concise when you come up, because sometimes we tend to talk and talk and talk and then get to the question. So the more that we can get that question concise, and then we'll have our answers concise so we can get through everybody's question. I'll turn it over to Pat.
So, Dr. Cantor, first of all, we've never really met personally, but I know who you are, okay? And I want to thank you for that wonderful presentation, because it was really a good presentation. It really made me think about a lot of stuff. One of the things that really, I've had, you guys actually, I've been in this a long time, as the doctors, the new doctors on the block, you guys came in as lifespan docs. So that was a little hard for our adult population, because you're moving from peds and taking care of people, adults with sickle cell disease. And the question was, do we want to hand our folks over to pediatricians, okay? I really appreciate the information you shared today. I have gotten a lot from it. I got a lot of rethinking to do related to that. As I interact with the adult population, I want them to understand, changes are made a lot of times without getting information from this adult population. And so the impact of those changes is profound, in terms of who they want to care for them and how they want to be cared for. And just listening to you talking about the different drugs that are available to them, because I know that the population I served, 90% of the adults with sickle cell disease did not have a problem with substance abuse. They did have a problem with mental health issues, but I had been a mental health nurse, so I was able to help them with some of those things. So I think that is really, really something that we really need to invest in, ensuring that everyone gets those kind of services. But I also think that we have to, there are a lot of decisions made without everybody being at the table. And I think that we have to include people living with sickle cell disease, as well as the people who they trust at those tables, so that we can make sure that they get everything they need. And if they don't get what they need, they understand why they didn't get what they thought they needed, And so I just want to again say that I'm glad that you came. I have wanted to meet you for a very long time. It wasn't always for good things. Sometimes it was to be ugly, and just share what the patient population felt. But thank you again for coming. And there's a learning curve that we've got to get past. I do believe that there are some people who need to be on certain medicines and who will benefit from it. I don't think it is a one size fixes all, and I think we need to keep that in our mind as we're medicating people with sickle cell disease. And then the one thing I really want us to do is to really get in there and change the way people are treated in institutions with sickle cell disease, because everybody has judgment on people with sickle cell disease and they don't really know them, And then that one question on the medicine that you are talking about, what is the percentage of kidney and liver involvement as a result of that medicine?
On buprenorphine or the new drug? So great question. There is almost no on either. The newer drug looks like it could have some liver issues, and it's honestly so new, I don't think we know, which is why I want to study it as opposed to just give it. And it's also why when we started buprenorphine, we did it in somewhat of a research way so that we could be very methodical. I want to say that I absolutely agree with you. It is not a one size fits all, nor should I have given everybody I took care of Oxycontin and oxycodone like I was taught. I also mistakenly sometimes told parents, if you give this to your child because they're in pain, they'll never get addicted. And that's not true. And I made that mistake. The other part is that most people aren't addicted, but they are dependent because of the way the drug works, and that's just biology. And so my friend, Dr. Carroll, who I learned more from than almost anyone I can talk about, Pat doesn't make a distinction. He's not going to tell you, he says it doesn't matter. If you are either addicted or dependent and you're miserable, we still need to help you feel better. And I think that's the point of the story. This is not for everyone. And I take care of lots of people who've been on that same opiate regimen they've always been on. They're 65, 70 years old. I'm not messing with that, right? I'm talking about people who are taking pain medicines, but still having to come to the hospital all the time. And that's the group that we've got to do better, because what we're doing isn't good enough.
So apparently we have folks online, and how do we get them to ask a question? Is there Dima? Is there
Hello, everyone. Thank you so much for being here. I do have 3 questions in the chat. The first is from Gina Sutherland.
So we'll just
asked-
take the first one, just one, and then we'll alternate. Okay.
Okay, perfect. The first one is from Gina Sutherland. She asked, what is the chemical composition of buprenorphine?
So it's an opioid that looks very similar to every other opioid when you look at the molecule itself. So it doesn't really answer the question I think she's trying to ask, which is why does it hit different receptors? And being the non-chemist in the room, I'm going to defer that to someone more knowledgeable. But the answer is that they all stem from opium at the end of the day, but they all do slightly different things with slightly different side effects.
Okay.
Okay. One from here, and then we'll come back to the online. Okay.
To bring to the table a consideration about pain in this world of pain management, that undermanaged pain actually increases your sympathetic nervous system reactions, can increase pain, can increase inflammation, and all of those things. So it's it's crucial for all of that to be balanced. And I would be super concerned about what happens so many times. You get low dosage and build up, and instead of a 3-day stay in the hospital, I'm there 10 days, because they're trying to, just kind of ease up gradually, see how this little bit works. And so, I just want to share that to make sure that's brought to the table in the big scheme of things.
I think that's really a great point, and we could have a whole nother day on acute pain management and assessment. There's a whole nother topic in my head that we're working on, which is treating pain and measuring crisis. Meaning we gotta stop conflating the two, because it's also why we have no effective drugs. We're so busy measuring pain and not measuring what's happening physically in the body. And so I really want to distinguish these two things, because we need to treat pain. And then we need to measure inflammation and vaso-occlusion, which we can measure. There's plenty of lab values that measure it. We say they're not because we're so scared people won't get the treatment they need. I think there's a lot of parts to what you're saying. So one of them is that true vaso-occlusion doesn't last more than about 10 days. Physically, that's just what happens in the body. It doesn't mean that pain doesn't last more than 10 days. And so we have to make sure that we're approaching those differently. Again, being very aggressive in our pain treatment, but not necessarily completely in step with how we're measuring what's happening. And so I think that we have a long way to go to differentiate those things. But I think that if we can impress upon physicians everywhere the need for acute aggressive pain management at the time of presentation, without saying, but where's your pain coming from? And take that out as to, let's let the hematologist and the sickle cell specialist worry about that. I think we'll do better.
Thank you. We're in trouble.
Online?
No, we're good. Okay. We wanted to have lots of time for this section. So we're going to take this online first.
Online first.
Then we're going to and then we're going to go to Nurse Jackie.
Okay. I have another question. Ayana Hatton asked, she's curious about how she can ask doctors about bringing up switching buprenorphine, especially doctors that are not open to it.
I think that's a great question. There's a lot of doctors who are actually quite scared. It's strange to me. You're not scared about giving them more dangerous meds, but you're scared of buprenorphine. But right, we know some things that we've done, we're used to doing it, so we don't like to change. I think there's a couple of different ways. One is we're hoping long-term, the National Alliance, to start a whole project that will help doctors learn how to implement this. Again, not for everyone, but so that there is so much more comfort Two, depending on what state you're in, we have sickle cell centers everywhere that can help. www.sicklecellcenters.org. There's over 120 sickle cell centers listed, which, by the way, is pretty awesome. We didn't know that that was possible. And each one of these, by being recognized as a sickle cell center, has to do pain management. And they all have a connection to myself, to Sophie Landskron, to everybody else who wrote those articles. And we get questions all the time about how to implement. So the first thing is just to ask your doctor. The second thing is, if your doctor is unsure, say, would it be okay if I put you in touch with one of the sickle cell specialists? And if it's still not okay, let's talk about finding you a different doctor who will listen to you.
And if I can just add to that answer as well, if you're aware there is a community-based organization like Kayan Wellness or others, reach out to them, because then maybe they can put you in touch with a Dr. Cantor, or a Pat Corley, right? So we can do that. And I want to really appeal. There are 4 folks standing there. We have just about 12 minutes left. If I do the math, that's like 3 minutes per question and answer.
I'll be fast.
So I want you to please, in asking your question, there's a technique to do it in one breath. If you can ask your question in one breath, get the question out. So think about your question as you're waiting, so you can really get it succinct. And then I'll ask Dr. Cantor to make her answers succinct. So we're going to go over here, and then we said we'll go to Nurse Jackie after. So to my right.
Hello, how are you? So my question is, what about those patients that come in and they are obviously in pain, and yet they're treated unfairly, put out the hospital, put out by security, some called, the police have been called on some patients. What about those patients who clearly have sickle cell disease? They're not coming in asking for more medication. As a matter of fact, they come in and when they're admitted, the physicians there will put them on more medication and then release them from the hospital. Like, okay, so then what do they do? What about that? I just want to know, what is your, take on that? Or when you go to a hematologist and you say, I'm having, for someone who's had a bone marrow transplant, and you say, okay, I'm having this pain, like acute chest syndrome, and I'm still having this pain, and they laugh in your face and they send you to psychiatrists, but they never tell you why they're sending you to psychiatrists. What about that? What's the, I would like to be, someone to help with that type of situation.
I would love to tell you that I could answer that in one breath. No way, that would take an hour.
How about 2 breaths? Maybe 2 breaths?
I'm going to give you the simplest answer first, and then happy to talk to you either later today or tomorrow, because it's a much longer answer. The simplest answer is everyone living with sickle cell disease deserves access to a sickle cell specialist. And that is my mission in the world. Starting in the United States, because we're not there yet. And so I think we should talk about it afterwards. Yeah. Because I think that the other part is actually after bone marrow transplant, and it's something that the Alliance has put together. We want everybody to go back to their sickle cell specialists, because the BMT doctors love them, but they would transplant my tree into a rose bush if I asked them to. So we want you to go back to the place where we know how to manage what you're feeling. And it's something we're working with our transplant doctors on warm handoffs to make sure you get back to a specialist.
But from the 90s, this is not happening?
What I want to ask Dr. Cantor, just can you briefly talk about some of the initiatives we're having to work with the ER docs, like the ACEP, which will probably address some of the things in terms of how folks are being treated and what we're working on?
I think we need to hear from her. We can't see you. We're trying to see, but.
What she's asking about is her husband has had a bone marrow transplant. He still has the symptoms that you talked about, the pain and the other things. They no longer have health insurance because he doesn't have sickle cell disease anymore, and so they are struggling.
So again, I would like to talk about it more offline so we can really personalize it for you, but it's to say that there are things that we can do, and clearly the pain needs to be addressed.
Yes, perfect.
Hi, thank you again for the lecture, really appreciate it. As I was introduced as Nurse Jackie, that might not be a good thing. But anyway, I am struggling with the docs at my facility for a multitude of reasons. So what I would like is how, in a beautiful world, we can get the doctors across the board to at least be on the same page. Is there...
So that's a great question, and it's something the Alliance is actually quite committed to. It turns out if you don't put it on paper, it's not real. So we've learned this. What I meant was when we said a sickle cell center needs a social worker, we would get dismissed all the time. When we put it on paper and said this is a requirement, suddenly it was made real. So that's why we put a lot of these recommendations on paper and are now, you can take this to your hospital and say, this is what the National Alliance of Sickle Cell Centers says you should be doing. And then if they're not, we can talk about next steps. But a lot of it, it's not so much shame, it's just saying now we have rules and you need to follow the rules. And people in administration are good at following rules, they're not good at being emotionally appropriate.
Thank you.
Do we online? We have one more online first. And then...
Okay. Yes, we do. I do have another question from Gina. He was asking if the drug in question changes the chemical composition or the white blood cell count like hydroxyurea can.
Oh, no, it's an opioid. It is a pain management. So again, this doesn't work to fix anything in sickle cell disease. Doesn't make the blood flow, doesn't make you break down your blood cells less. It just treats pain.
Okay.
So next up.
I'm sorry, I got a couple questions. I'll try to ask them fast. One, should Butte be continued in the hospital during an acute crisis?
Most of the time, yes, but not 100% of the time. So sometimes we stop it for a day or two to really allow Dilaudid or morphine to sort of have its best potency, and then restart it and titrate it back up. But either way is totally safe.
Okay, and what's the difference between synthetic opioids and opioids, like the effects it has on the body?
A much longer conversation.
Okay. And can receptors go back to their default state?
That is such a great question. Yes, we can see that pain receptors can, but they don't always. Just everything is heterogeneous. So I have patients who are now 5 years out of bone marrow transplant, and they still take Suboxone 3 times a day. I have other patients who wean themselves off and are 100% fine. But I will tell you that when they started it, all of them were miserable, and they're so much better now. And I don't know exactly what it is about that drug, or if it's just time, or what it is. I think that the biggest part is that the buprenorphine doesn't worsen the pain receptor problem. And so if you're not continuing to activate that pain receptor problem, you can slowly allow yourself to heal. Whereas the other opiates continue to activate it. And we'll even see, I have a specific individual patient who every time she does have a crisis and comes in the hospital and is on Dilaudid, she's miserable for weeks as I get her back onto buprenorphine because all of her pain receptors flared. And so it's very individualized, but it's important to recognize that as well.
I had two questions. I'm going to make it really short. First thing, I know you said in your presentation that people from other countries have less crisis or something like that, or
take less opioids.
Take less opioids. Is it, number one, because they have better food options, less processed food and things like that? They have a better way of living in some countries? I mean, as far as food go in their intake.
I think that's an excellent question, and I would honestly tell you the answer is no.
Okay.
That may also be true, but the real answer is it's a different approach. Pain became the 5th vital sign in the United States alone, and that didn't happen in some of these other countries. And so they still stuck with young kids in treating pain with the least aggressive medication first, and they just didn't use these meds at home. They felt if you were sick enough to need a strong opioid, you should be in the hospital. You shouldn't be at home. And in a lot of ways, that can be very frustrating, right? Because now you don't want to go to the hospital when you have pain. You want to be able to manage it at home. And as they become adults and have an understanding, then they are given more opioids at home. But it prevents the McDonald's versus cooking food problem. And I think that's a real issue that I think is human nature. We try to do what's easier and fastest to give our kids relief.
And I'm sorry. I just want to also have us just take a pause with that. And when we talk about things that are happening in other countries, we have to really look at the differences in the lifespan. So in Africa, the life expectancy of a child born with sickle cell, many of them don't live to be 3 or 5. Here in America, we have
And I'm talking specifically about high-resource countries when I'm having this. I'm talking about England and France and high-resource
right, I
countries.
understand that, but I mean,
different.
So again, balancing, because there are a lot of people that end up in those countries too, even where it's high-resource countries. You'll have the immigrant population that's, how can I put it, much more of what we think of as the unicorns. Does that make sense? Yeah.
Yeah, okay, and my other question is, you said low-dose medications. I seen on there Tylenol as an option for something. I'm not even sure if I missed something, but can you explain why is that an option?
So IV Tylenol can actually be an incredibly effective therapy, and when given at the right dose at the right time.
But I'm saying in the hospital?
Yes.
Okay.
At home it can be, but IV Tylenol as a first-line therapeutic can be very effective.
Okay, and I think that's for different people then, correct?
No, for sickle cell too.
Yes, IV.
IV Tylenol.
IV Tylenol. Okay, I didn't see that.
Yeah, IV Tylenol can actually be very effective.
Okay.
But
Yeah.
it's a good.
But and that's part of the conversation. Why not, right?
Yeah, back to why not. When you can get it. Dorian.
So I have a two-part kind of question comment. I think one of the greatest.
Just one second, Dorian. We have a last question here at the podium. Thank you.
I think one of the greatest issues that we face as sickle cell warriors, and I think I heard that echoed up here across many questions, is the consistency of care that we experience both in the emergency room as well as admitted patients. So I'm glad you brought up, putting it on paper, but even when it's on paper, we still experience that lack in the consistency of care. Whether it's them not following ASH guidelines, NIH guidelines, those kinds of things that are on paper. What avenue? I know you guys have many initiatives that you guys run specifically for that. What would you say the best resource would be for sickle cell patients who are experiencing that lack in consistency repeatedly?
So one of the things it's a great question that we try really hard for is ensuring that when you have a sickle cell center, that they control sickle cell disease within the hospital. So if you come to my hospital, there's an individualized care plan that the ER uses, that my hospital uses. Sometimes they use my name in a dirty word, like somebody wanted 2 bowls of oatmeal and they said no, Dr. Cantor said no. Dr. Cantor didn't care about the oatmeal, but you can understand that it is consistent. So one thing to talk to your doctor about is, where is my pain plan? Can the ER see it? Can the hospital doctors even see it? Because it turns out that's not as obvious as you think, and sometimes they may not know that.
Great. Thank you so much for that reply. And also, I just wanted to say, in terms of creating those care plans, I myself was probably on 270 pills of morphine a month at one point in time. And through making a care plan with my doctor, I was able to reduce that by almost 2/3 using buprenorphine, naloxone in combination with my immediate release opioids. So I did just want to add that caveat for any patients who may be scared or trepidatious around using those new methods. So thank you.
Thank you so much, and so please thank Dr. Cantor, Dr.